All right, guys, welcome. Thanks for taking the time to join me. I know it was kind of last minute, but I've been in communication with you guys and trying to get a feel for when we can all meet. But this works out really well for me. This is the first time that I've done more than one student at a time, but essentially, kind of what we're going to be going over today is a lot of lecture, but it's back and forth communication. So, Kevin, you got the equipment, and Charles, you haven't got yours yet, correct?
No, I've actually got mine. I got mine about an hour ago.
Oh, you did? Oh, nice. Good. So some of that stuff we'll be using a lot and continuously. I might reserve some of these skills for some one-on-one sessions where it's a little bit easier to focus on what's going on with you guys. But first off, a little bit about me. My name is Adam Knight. I am one of the co-founders and instructors for the company. We started the company in 2009 after a bunch of us got together, 4 of us actually, and decided that we wanted to offer an online venue for EMT and fire training within the fire service and for emergency services. The typical makeup of our students are students that are young, such as yourself. We have the people that have been in construction for the last 20 years. They hate it. They're tired of putting up drywall. They want a career change. So they're in their mid, late 30s and they end up going to the fire service. And then we have retired Air Force colonels that are bored and they want to come and take our class. And then they come back for our advanced EMT class. Some are fire service, but really the majority are not. They are civilians that are looking into getting in the medical field or maybe helping out the community, but they're not sure how they're going to do that yet. Some students take it for pre-med purposes. It's an extra class to get under their belt, especially during the summer. And they go back to college, just like you're doing, Charles. But that's only one half of my story. The other half is that I'm a captain with a local fire department. We're a fire-based EMS system, which means that we have ambulances in our fire station with our firefighters running them. And overall, just our fire district and the area we live runs about 7,000 calls a year, give or take. We're an all hazards mitigation fire department, so we run anything from a fish hook in the neck, like my call at 6 o'clock last night had a hook in this girl's neck, and the guy essentially wanted us to put lidocaine in it so he could rip it out, but he needed us to hold his daughter down. And I said, we're not doing that. That's not within our scope of practice, and it's not something we do, torturing little girls with fish hooks in their neck. But we do everything else, car wrecks, structure fires. We've got a fireboat on the water. We do wildland fires. And if you end up going the fire service route, most likely it will be all hazards mitigation. And EMT is just a check mark on that box or checkbox. So where are you guys from, and what do you plan to do with the class?
So I'm from Wakanda, Illinois, but I go to college in Virginia. I'm a member of the Virginia Tech Corps Cadets, and I mainly took the course to help prepare for the cadet training that's going on now about a week, because I'm on EMT staff there, and part of the requirement is I have to be a licensed EMT in order to be there. And I'm also hoping, because next summer I'll be enlisting in the Coast Guard Reserves, and I'm hoping to take those skills and apply them when I join the reserves.
Good. That'll definitely help. How about you, Kevin?
I'm from Maryland, going to my second year in college right now. I'm thinking about going on the pre-med track, so I thought this would be a good experience for me to get into it.
Yeah, it totally is. I don't befriend every Facebook or every student on Facebook that comes through, but I do watch a few, and watching them progress through medical school and through their graduation has been pretty cool, pretty rewarding. A lot of it started with us. So very cool. All right, so you guys got those boxes. Do you guys have any questions with what's in there and how to use certain things? Some of the stuff you're going to recognize from pictures from the book. Others, you're going to go, I have no idea how this works and what it's for. Any questions?
Was it supposed to come with the long backboard?
That's a good question. So that is something, Kevin, that we changed about a week ago. We're no longer going to be sending the backboards out, so you did not receive them. We're still going to talk about backboarding. We're still going to talk about the indications of using the backboard, why you would, why you wouldn't. However, it is a skill that the National Registry has removed from the psychomotor exam if you were to take that exam somewhere. And it honestly is something that is used very rarely anymore because this is not needed. Most of the time it's used for a lifting and moving device to move a patient from point A to point B. But as far as that cervical spine protection, it's not as necessary as once thought. We still use them and we still have to be competent in them. It's just not something that's going to be used as much as we normally used to. One thing that's going to be difficult is to really assess your ability to properly check vital signs. Charles, you have a little bit of leg up with your dad, but take that equipment and start using it as soon as possible. Check those blood pressures on your parents, siblings, friends, whatever it may be. Just so you can get a feel where that radial pulse is on the forearm, where your other pulses are, what a normal blood pressure might look like. Kevin, do you have any experience with vital signs or?
No, I mean, I've been practicing it on my parents a few times, but I think I'm still having a hard time, like, especially with like the pulses here and like, yeah, just feeling that.
Good. Well, that's okay. As long as you have someone to practice with and the ability to start evaluating what that feels like and that looks like, I can certainly work with you one-on-one when you have somebody and tell you what to look for and what to feel for. We advocate to check that pulse at intervals of 15 seconds and then multiply by 4. If you starting out, if you want to count for a full 60 seconds to get that pulse, then that's what you can do.
Okay.
So great. All right. Can you guys hear me okay?
Yes, sir.
Mhm.
All right. I'm on my front porch because I don't want to be inside. It's cooled off to an awesome 86 out here, and I'm going to take advantage of it. Yeah, the majority of that equipment we'll be using as we go on. Let's start off with something fairly gentle, and that's going to be the medical assessment. This is where the back and forth communication, I'll probably specifically ask you, Charles, okay, what's this intervention? All right, Kevin, give me a nature of illness, which is like a chest pain or difficulty breathing. And then we'll go through those nature of illnesses, the medical emergencies that we could come across. And then after that's all done, we will identify the different interventions that we may use, such as a meter dose inhaler or nitroglycerin. We're going to talk about the 5 rights. We're going to talk about the dosages. And that's going to take up the majority of our time. So the medical and trauma is what you're mostly going to do, getting a good assessment down and determining what it is. So for example, if you go to a chest pain patient, is it truly chest pain, or did somebody get kicked by a horse? Is it an anxiety attack where somebody's having difficulty breathing? Is it muscular versus cardiac in nature? And so that's where a good assessment, a good sample history, going through your OPQ or ST is going to paint a picture. And then you're going to be expected to document all that stuff as well. So we'll just start with you, Charles, and what's one nature of illness?
Repeat that again. Sorry, you're breaking up.
What's a nature of illness that we may come across? What's a medical emergency?
We could come across someone who, you touched upon it, but chest pain, but also abdominal pain,
Okay.
Pain related to gastrointestinal, that kind of thing.
All right, GI, abdominal. All right, Kevin.
Like airway,
Okay.
airway problems. Immunologic emergencies.
Okay, we're gonna go airway, respiratory type stuff. All right, Charles, what's another one?
We could be dealing with geriatric medical emergencies. Would not the nature of illness, actually.
That's pretty general. Yeah. Maybe something more specific.
Soft tissue trauma.
Let's stay on the nature of illness right now versus mechanism of injury. But
Okay.
yeah, you could come across the soft tissue stuff, tears and skin tears and such. You know, even if you have to think back to maybe something happened to you as a kid, or maybe there's something going on now, you don't have to share it, but something that you've got experience with maybe grandparents, parents.
Mhm.
Anything?
Cardiovascular emergency.
So I'll lump that into chest pain.
Okay.
What else, guys?
Would you count infectious, like pathogens? Would that count as an illness, or that more of a nature emergency?
Let's call that sepsis. So an infection, full body infections. Okay. What else?
Like fractures, orthopedic injuries.
That is something we will come across, but that's I'm trying to separate trauma versus medical.
Oh, okay.
So you guys are definitely on the right track, but you're missing a lot. What did you guys read about? If you go to a park and someone's lying on the ground doing rapid movements, what might that be indicative of?
Oh, seizure.
Seizure.
Okay. Yes, seizure. If somebody has a facial droop, what can that
Stroke.
indicate? Stroke. Good. If someone is slurring their words and they're very diaphoretic and they're not making sense, or they may even be unconscious with snoring respirations, what might that be?
Hypoglycemia.
Hypoglycemia, so diabetic emergencies. Good. All right, anything else? You go to a rough part of town and you are dispatched for an unconscious. You arrive on scene and find a tourniquet tied around somebody's arm. What might that indicate?
Overdose.
Overdose. Good. Good. Excuse me for one moment. I'm going to go grab some more notes, and I'll be back in a couple minutes, okay? Feel free to grab your books and have them out and thumb through certain things. It certainly isn't a session that I want you to be going through every page and reading me verbatim what you were tested on, but I'm okay with jogging your memory and something maybe you need to take notes on or highlight. So I'll be right back. Each one of these medical emergencies have a intervention that may or may not be used, up to and including maybe just transport, but we have to mitigate it some way. Some have a little bit more specialized medication that you can assist with or administer, depending on whether they're prescribed it or what have you. So let's start off with chest pain. what are the signs and symptoms of someone having cardiac chest pain?
Obviously, like discomfort around their chest area,
Yep. Yep.
like a sort of tightening or like weight on their chest.
Exactly.
Sometimes like cold, clammy skin.
Yep. Yep. Correct. And someone truly having a MI, which is a myocardial infarction. So myo, muscle, cardio, heart muscle, infarction, which means cell death. There's something going on in that heart that is, there's an occlusion of a vessel not allowing that oxygenated blood to reach the certain section of the heart, causing that chest pain. You may have all of the telltale symptoms, or you may just having someone with a little bit of arm pain, arm discomfort. Maybe it's just kind of tingling. They don't know why. They were out mowing the lawn. They thought they just did a little bit too much strenuous work. But what you guys described and I described is something that indicates possibility of a heart attack. I have minimized some calls where there's someone that's 30 years old, they're having chest pain, and they just don't fit the bill. They're not totally unhealthy. They don't look like they're having a heart attack. But in all reality, they get hooked up to the monitor, they go to the hospital, get blood drawn, and they are truly having a massive heart attack. So there is an age range, which is older, our parents' age, and you might expect something like that to happen. But it can come in all shapes and sizes, signs and symptoms, and age groups. So what is something an EMT can do to assist with that chest pain, with making it better?
You can give the patient low doses of aspirin if they're complaining of chest pain, but assuming that they're not allergic or that the aspirin will not interfere with like any other treatment.
Great, good answer. So once you do a good sample history, let's just talk about acronyms for a little bit, real quick, before we jump into aspirin. So what is a sample history? What does that involved? And I appreciate you guys just kind of jumping in and interjecting. I know that there can be some awkward silence, like, oh, I think it's his turn to say it. I don't know if I should jump in, but you guys are doing great. Charles, let's just start off with S. What is the S for sample history?
The S in sample history starts for the symptoms and the signs, correct?
Yeah.
Is that correct?
Correct. Kevin, what's the A?
Allergies.
Allergies. Charles, what's the M?
Second. The M stands for medications.
Correct. So oftentimes you get a baggie of medications or a box of medications. Sometimes you get a ton of vitamin supplements that are in there. Really, you should be documenting all of that stuff because you don't know how it interacts with each other. Sometimes they'll tell you ahead of time, hey, I don't take the Ambien anymore. It makes me feel funny at night. Or I don't take this anymore because of whatever reason. So it may still be in the box. You can set that to the side. It's not current medication. Kevin, what's the P?
Pertinent medical history.
Correct. So pertinent medical history. I don't care that they had a total knee replacement 10 years ago. It is typically, most likely not going to be why they're calling today. However, if they had a knee replacement surgery 10 days ago and they're now experiencing chest pain or difficulty breathing, I might be considering that they're having difficulty breathing because there was a blood clot and now there's a pulmonary embolism. I can't diagnose that, but I can do a good assessment and determine that, what it may or may not be. Pertinent past history. So a heart attack 10 years ago is pertinent. It is cardiac in nature, and it is certainly something that could be reproduced during this time. So, if they had a triple bypass or stents placed, if they have a history of high blood pressure, high cholesterol, those are all together could cause somebody in poor health a cardiac event. Pertinent past history, COPD, CHF, diabetes. There's a myriad of things. Charles, what is the L?
Last oral intake, when they last took that medication.
Correct. What is that? Why do you care when somebody last had a peanut butter and jelly sandwich?
Because there could be a reaction caused by the medication, or that could impact their ability to properly for their body to come. I'm struggling with the words, but it's like to see what their body's reaction was, and like when they've last had food, water, anything like that, or medication.
Yeah, great. Yeah, you hit it on the head. You don't know what they had a reaction to, and it might indicate that they. Sorry, there's a bee flying around. Might indicate what's going on. And Kevin, what's the E stand for?
The events leading up to the illness.
Okay.
Like what they were doing. Yeah.
So bring that into context for me. What do I care what they were doing before they called?
Like if they were doing some strenuous activity that might have caused them to like feel that chest pain, or if they were just sitting down, not doing anything, it just suddenly came along.
Yep, correct. So if they're out mowing the lawn, they're 75 years old, now having chest pain, is it overexertion, or is that chest pain going away? Is it getting better with rest? Does it go away as they take a breath? What was the activity? Maybe it was a domestic dispute, and it's a 22-year-old male having chest pain, and they're just calming down, that, like I mentioned earlier, that anxiety. So what is the events leading up to it? OPQRST is another acronym that's used, and it is really comes into play, especially with the medical emergencies. Depending on the trauma and what's going on there, you could use it for that. But you guys recall reading that in your book? OPQRST. Yeah. All right, Charles, what is O?
Onset.
Onset. Well, it started it kind of like the events leading up. Kevin, P.
Provocation, or like the palliation, I think.
Right. Provocation. What makes it worse? What makes it better? If you lift your arm up or I push in a certain spot, does that make it worse? We'll go back to chest pain. If they're having chest pain on the left lateral side, that's the side that the heart's on, but is it a broken rib? Is it a bee sting? Did they fall and there's a pine needle just poking them? So OPQ, Charles, Q.
Q stands for is the quality of the pin.
Yep. And how would you use that in a form of question during your assessment?
You can ask them how does the patient describe the pain? Is it like a dull pain? Is it like burning, crushing, tearing? The sensation of the pain.
Yes.
Because when you say I have pain, that's a pretty general statement.
Yes. Good question. And Kevin, R.
Radiation. So does the pain radiate anywhere else?
Yep. So if it is a the cardiac emergency, if it radiates that right arm or left arm, what's typically a true cardiac patient doesn't have radiation to the right arm. It could happen. Say somebody with an abdominal pain, appendicitis. Is it a diffuse pain across the abdomen? Is it pinpoint in the right lower quadrant? What type of pain is it? Where is it at? Does it radiate anywhere else? Good. Charles, OPQRS. What's the S?
S is the severity.
Yep.
Of how bad is the pain, like the 1 to 10 scale, or if I can remember this correctly, it's like the FACE scale for children and or people who are nonverbal.
Yep. Good. Exactly. Quantify that pain scale for them. What is it? Don't just leave somebody as an open. Don't just leave the. Sorry, something popped up. Quantify for them. Don't just ask somebody, how severe is that pain? Well, it's really bad. Well, how bad is it? What do you want me to ask? So give them a scale. 10 being the worst pain you've ever had. 100 being the worst pain you've ever had. Mostly it's on the 10 scale. That's what we teach, and that's what works really well. A lot of the hospitals use that scale as well as the face scale. And T, who wants to tackle T?
The timing of the pain.
Yeah. So length of time, that abdominal pain. How long have you been having that lower right quadrant pain? Well, I've had it for about 9 days. And I know it's 3 o'clock in the morning and you guys are sleeping, but I really want to go to the hospital right now. So we get a lot of people that call in the middle of the night because they want to go right now. And they can't wait till 6 o'clock in the morning. They have to go right now. Yeah, how long has it been going on? Talk to them. Get a story from them. Build a rapport with them. Don't talk at them. Talk to them. Build a rapport. So, good. We got sample OPQRST out of the way. Do you guys have a chance to look at the National Registry skill sheets?
A little bit. And
Yeah, I think I've glanced at it.
Okay. Those will help you immensely get through this class. Of course, just reading, something I tell you to read doesn't mean a whole lot until we put it into practice. But knowing those skill sheets will help with this overall assessment. So, making full circle, back to the interventions. Charlie, you mentioned aspirin. Now, before we give them any medication, what are the 5 rights? 5 rights medication. Yep.
Right patient, right drug, right dose, right route, right time. Is that correct?
Yeah. So patient, prescription, right dose, right time, and right route. You concur, Kevin?
Yeah.
Okay. So if, Kevin, if I'm going to give someone aspirin, before we even go to that too, sorry. So your protocols, wherever you're going to practice medicine or emergency services, are going to have protocols specific for that agency, that county, and that state. The interventions we are talking about today are in general. They're within your training at the EMT level, and they're mostly accepted across the U.S. at the EMT level. But there may be some extra training your agency gives you to where you can give another intervention or another medication. And so I just want to emphasize this. These are in general, these are not my protocols where I live. They're not Denver, Colorado's protocols. They're just in general. So Kevin, aspirin is typically given at what dose for the cardiac patient?
I think 15 milligrams.
Nope. So typically you give 4 baby aspirins so the patient can chew on them. So the route is PO by mouth. But what is the dose? Want to help out, Charlie?
I'm trying to think on it. For like 1 baby aspirin or like the 4 baby aspirin?
Well, what's the dose of 1 baby aspirin? We'll start there.
80 milligrams?
81.
81, okay.
Yep. So you have You give 4, and they're 81 milligrams for a total of 324. You will also see it referenced as 325 milligrams because that is what's in one adult dose of aspirin that somebody will swallow. There's also protocols and such out there that say that 162 milligrams is enough. Currently, we're teaching the 324. What does that do for the cardiac patient? Why aspirin? You guys recall reading about that?
It's a blood thinner.
Okay.
So like, if there's like some sort of clot, it makes it easier for the blood to get through still.
Right. Yeah. I kind of look at it as it makes the very basic level. It's a thinner, but it also makes it the blood cells like slipperier, so they're not going to tend to clot as well and add to the problem of the chest pain or the myocardial infarction. So what's another medication associated with chest pain patients?
Nitroglycerin.
Nitroglycerin. Okay. Charles, what is the route and dose, and when can we give it?
The dose you can give it. Hold on a second. Usually, nitroglycerin comes in tablets, and you can give it after usually of the sample history. However, you need to ask if the patient has ED or takes medications for ED because that can cause issues within the patient. And I don't remember the dosage though. Sorry.
That's okay. So it's indicated for patients having chest pain. You're correct. Someone that is taking erectile dysfunction drugs can take it, and those drugs have the same effect that the nitroglycerin is going to do. And Kevin, what does that nitroglycerin do for the body?
It dilates the blood vessels.
Correct. So it's a vasodilator. It dilates, allows more blood flow to go maybe around a clot. But it also does something. There's the symptom that occurs that when somebody takes a nitro. Decreases their blood pressure.
Yeah.
So there's a contraindication to giving nitroglycerin. What is a contraindication? Meaning a reason why you should not give it. What is that reason? Or I mean, what is that contraindication?
Their blood pressure was below 100.
Yes.
Yeah. And if they're taking ED pills.
Yes. Good. Exactly. So someone is having 10 out of 10 chest pain. It's indicated that we can assist with nitro. So we can't grab nitro out of our bag and then give it to them. If it is prescribed to them, we can ask them, have you taken your nitro yet? No, I haven't. Have you taken any erectile dysfunction medications? No, I have not. You take their blood pressure. It is 140/76. Okay, it's indicated that it's acceptable to give it. You pop a little pill in their hand, and how do you have them take that pill?
You have to take it orally.
Orally, okay, good. You put it in their cheek. You just have them chew it up, swallow it. What do you have them do with it?
So under the tongue.
Yes. So you're taking it sublingual, put it underneath the tongue. So do you recall what I'll just tell you. So you put it underneath the tongue, and a nice fresh nitro is going to cause a little bit of burning, and the patient might say that they have a little bit of a headache. That's an indication that it's a good one. It's working. It's the right route, right dose. And the dose for nitro, Kevin, do you recall?
No.
Okay. 0.4 milligrams. 0.4 milligrams.
Okay.
So with these interventions and these dosages, it by all means, we're in training, guys. I don't expect you to know every little thing that we're going to come across. But before our assessment skills are over, I'm going to give you a scenario, and I'm going to expect 100%, especially with the medications. If we give a medication dose error, or we give them the wrong medication, that's negligence, and that person, if there's anything that happens to them, your patient dies or is injured in any way, that's a very bad thing. You could lose your licensure, be sued, lots of different legal things. So if you're a little bit rusty on these today, that's okay. Do some studying, write these things down, learn them, learn how they react, and it's not really that long of a list. So I also recognize that as you take an online class that's self-paced, it's not really emphasized to you what's really important until you have an instructor tell you this is really important. So there's also some things with medications on how often you can give that medication. So some of them, it's one dose and you're done. The aspirin is one 324 milligram dose and you're done. If they take a daily baby aspirin and it's now 4 hours later, you only give 381 milligrams for a total of 324. That includes the dose that they already took for the day. If they already took a 325 milligram pill, then you document it as such. You don't do that again. So nitroglycerin, 0.4 milligrams, and once you administer your first dose, how often can you give that next dose?
15 minutes.
Okay. Kevin, do you agree?
Yeah. If their BP is still over 100.
Okay. So depending on what's going on, how long your transport is, you can give up to 3 doses of nitroglycerin as long as their systolic pressure is above 100. The other thing with medications, or if you're transporting someone, you're like, I just don't remember what to do. You can reach out to medical control via phone or via radio and ask a doctor that's on call in your emergency department, hey, I've got this chest pain patient. He's complaining of 9/10 chest pain. I've deemed it to be cardiac in nature. What's a good course of action? You want it? What do I do? I'm a little bit lost. I'm new. So it's okay to ask questions. That's what they're there for.
Okay.
The other very important thing to consider, and it shouldn't even be considered, it should be automatic, is that any chest pain patient, you're going to need ALS intervention. So cardiac monitoring, in case they'll go unconscious, they can, their cardiac medications, cardiac monitor, they can intubate. So whether it's a paramedic by ground or it's a aeromedical helicopter in your area, maybe you're responding to a rural location, you should always have a paramedic en route for these type of patients. So, all right, let's jump to respiratory and airway emergencies. There are several nature of illnesses that can be included in this topic, and some of those are COPD, CHF. You could have something as simple as anxiety, respiratory or difficulty breathing. That's kind of what we're going to categorize this as. Could be associated with the chest pain. An allergic reaction. And, you know, someone having a stroke might have it. Someone having an overdose is going to have some respiratory issues. So let's take it with, asthma is another one. So COPD and CHF. Dispatch for a 80-year-old male. You arrive on scene. He's in a tripod position. He's leaning forward. His hands are on his knees, and he cannot breathe. What do you want to do for this guy?
First, like listen to, like determine his breathing rate and whether it's adequate or not.
Okay. Yeah, that's definitely one. Let me emphasize too is that when you are responding with a crew, whether you are a nurse in the ER or whether you're part of a crew, an EMT crew at your college, you're going to be tackling this assessment together. So you might direct somebody to go to take vital signs while somebody else checks. I'll give you a little example. We had a guy, we were dispatched, we were right down the road from the call yesterday, and the guy just said, I need an ambulance. So we didn't know really what we were going to. We get on scene, this guy's throwing his arms up and down, and he's pointing at the wall, pointing at his bike, and things just weren't adding up. All in all, it was a psychological emergency, but he said, I'm dying. Take me to the hospital. Well, what's going on? I'm dying. I'm dying. Somebody almost killed me. I'm dying. I'm having difficulty breathing. I'm dying. And so we really had to determine what was going on. So while my crew took care of him, he gave us permission to go through his bag that was on his bike, and I was really more worried about weapons. He said, no, go ahead, look all you want. What I was really looking for was any indications that there was drug use, maybe some empty pill bottles, maybe a lighter with a burnt spoon, or some a piece of foil with maybe some drug residue. And I didn't find anything. I don't know, all in all, what the medical emergency was. I just know that he needed some comfort and needed us to take him to the hospital. And what I'm trying to emphasize is that we tackle that as a team. So this COPD, CHF patient's having difficulty breathing. You assess his breathing. He is breathing at a rate of 22, and he's taking these big deep breaths, and he's just feels like he can't catch his breath. What do you want to do for this guy? Check his vital signs. He's got oxygen saturations that are 84%. What's an intervention you can do for this guy?
You can administer oxygen.
Great. Excellent. And I failed to catch that with the chest pain patient, but they also need oxygen at a high flow rate. And what would that rate be, and how would you administer that oxygen?
Through NRM, 15 liters per minute.
Yeah, 15 liters per minute. How?
NRM.
Okay, non-rebreather mask. Okay, good. Or non-rebreather mask. Okay, NRB. What if he doesn't like it? He doesn't like how it feels on his face, and he wants, he's still huffing and puffing, but he won't keep that mask on his face. Can you switch to?
You can advise him on like what the risks are if he refuses the treatment or wearing the mask.
Okay. And what else?
Can use the nasal cannula.
Great. You can use a nasal cannula. And Charlie, what's the proper rate of delivery for a nasal cannula?
The proper flow rate is low, so it's 1 to 6 LPM.
Yeah.
Correct?
Yep. And what's LPM stand for?
OPM stands for liters per minute.
Good. So liters per minute, the regulator that you guys have in your boxes is measured at liters per minute. So it's got a dial. Before we do those skills, make sure you watch those videos I told you about and practice that. That way when we do this live session, it's just smooth and we get that done. Okay, so for the conscious and alert patient having difficulty breathing, specific to COPD, CHF, this is about all that we can do. Let's change and go to someone having an asthma attack. Someone that has a history of asthma will typically carry something with them, and something that if they haven't already done it, we can assist with administering it. What is that device? Or a medication? Their inhaler, yes. So it's a meter dose inhaler. Somebody says, I have asthma. They pull it out of their pocket. They hand it to you. What do you want to ensure?
You want to ensure that that the inhaler is clean, so that way you want to ensure there's like no dust or any particles surrounding the mouthpiece.
Okay, that's I consider that. The other thing I would consider is it theirs? Is it prescribed to them? Is it the right dose? Is it the right medication? Is it the right time? So consider your 5 rights. That's something that, again, I'm just re-emphasizing. So typically for someone, it's going to be albuterol, Atrovent, maybe a little something, maybe some steroids. But how would you assist them? Maybe it's new to them and they've never used it. And they give it to you, go, I don't know how to use this. Tell me. Give me some information. How are you gonna help them?
So I'd first tell them to like exhale completely or as much as they can.
Okay.
Then when I press the inhaler, tell them to inhale and hold it.
Good. So yeah, put it in their mouth. Tell them, okay, I'm gonna squeeze it and you're gonna take a deep breath. Try to hold your breath as long as you can and then exhale. Okay. And there will be some directions on how many puffs you can give them, what the doses are going to be, so on and so forth. So we had COPD. So the anxiety of patient. So someone's having anxiety. They're freaking out for whatever reason. They're having a bad day. It may be the first time they've felt like this, and it may be something that happens once a month. How are you going to treat them, or what interventions can you do?
Give them specific directions, like tell them breathe in through your mouth, breathe in through your nose, out through your mouth, like just general, not don't be forceful, but try to calm, get them somewhat calm so that their breathing is not they're not hyperventilating.
Yep. A lot of times these people will be kind of distraught. They just aren't making any sense. They're numb. Their hands and fingers will start tingling. Sometimes they can't control it, but their hands will kind of start doing this. The pathophysiology behind it escapes me right now, but has to do with the oxygen and CO2 within their body. So they're blowing off more than they should. So first thing you're going to do is they're having difficulty breathing. Your protocols are probably going to indicate someone having difficulty breathing, you administer high flow oxygen via non-rebreather mask. So that's may or may not be what they need. Oftentimes what I try to do is talk to them. I get close, I talk to them in a really calm manner so they can understand me. I tell them who I am, that I'm here to help them. And I say, hey, breathe with me for a minute. Take that deep breath. Take a deep breath in. All right, good job. Hold it and let it out. And I just slowly start breathing with them. And so even though I take that deep breath and they may breathe 3 or 4 times before I tell them to breathe out, they will start slowing down their breathing. Oftentimes it results in a non-transport. It's more of a psychological thing versus medical emergency, and you can give them calm down. Normal people have anxiety attacks. It's not a sign of weakness. It's not a sign of mental instability. Depending on people's ages and the traumas within their lives, maybe they just lost a loved one. Maybe they were denied a promotion at work, and something has just triggered them to have anxiety. And some people live with it every day, and maybe they're out of medication. But it's something with a little bit of coaching and counseling, you can revert that and help them out. So allergic reactions, regardless of whether it's a shellfish, penicillin, bee sting, they all look different. So what are some indications of an allergic reaction? Signs and symptoms.
They might see, oh yeah, you can go.
Difficulty breathing is kind of a general one you'll see for allergic reactions.
Okay. So difficulty breathing is what we're talking about. It's more of a severe reaction or maybe a delayed reaction. It dependent on someone's allergies. It could have been a piece of crab they ate 5 minutes ago, or it may be that they ate it 6 hours ago. They've had a progressive swelling of the throat and tongue, and now it's a delayed response, and so this thing has progressed much further than it should. So what are some other indications of an allergic reaction?
Hives is another sign of allergic reaction.
Yep. So you're going to be looking for the urticaria on the skin, the hives, red bumps. It may not be in their arms or their face, but if you lift up their shirt a little bit, you're going to see it on their stomach, maybe on their legs. I had one patient that was stung, and every single spot that he was stung before in his life decided to swell. It was a totally atypical presentation, but that's what happened. He was having difficulty breathing, and we provided an intervention for him. Now, someone having a severe allergic reaction, what is that intervention?
The EpiPen.
EpiPen. So some sort of epinephrine auto-injector, or some agencies choose to have their providers draw it up. It's a 1 to 1,000 epinephrine saline mix. And what would be an adult dosage? It's an adult dose for Epi.
Good. .3 to 0.5 milligrams.
Yeah, typically your EpiPens are going to have 0.3 milligrams. Depending on your protocols, I think ours say 0.2 to 0.5. It's fairly ambiguous, but the EpiPen auto-injectors will typically deliver 0.3 milligrams. So if an adult dose is 0.3, what is a pediatric dose?
0.15.
0.15. Let me go grab one of those so you can see what I'm talking about. Just happen to have one in the car for my kiddo. But so this is a 2-pack. It has your correct dose. It has the patient's name, so the right person. It has the correct date. which that is not the expiration date, that's the date it was issued. Within the EpiPen itself, it's going to have, as I said, it's a 2-pack. The adult dose is going to be in the same size of packaging. It's going to be yellow in color. Again, it's dependent on the manufacturer too. This one is manufactured by Mylan. So this is what theirs looks like. So this one has directions right on it, how to do it. Remove this cap. And then where do you put it?
The upper thigh.
Yep, put it in your upper thigh. And how long do you hold it there?
5 seconds.
So depending on the book, this specifically says 3 seconds. So 3 to 5 seconds is kind of a newer thought process. Some of the older EpiPens will tell you to keep it in there for 10 seconds, but we know that it fairly rapidly goes through the syringe into the muscle, and you don't have to hold it there as long. So this one shows that it is expired. Lot number expired November of 19. So I really need to get this replaced because it's expired. So it also indicates that it should be stored in a 68 to 77 atmosphere. The hot car all summer long is not a good place to keep it. So essentially, I should throw this away or use it as a trainer. But stuff does have a shelf life, and it's fairly expensive to replace. So a lot of your patients will have these expired EPIs, and by all rights, if it's expired, you should not assist with administering that. You can definitely contact medical control, tell them what you have, and then ask for guidance from there. All right, make sense?
Sense.
I lost my pen. Lost my pen. Okay, so EpiPens, adult, 0.3. And these are things you're going to be tested on as well. And it's something you could see on the National Registry test. Can't guarantee it, but. Okay, let's jump into, do you guys need a break at all?
No, I'm good.
I'm all right, yeah.
Okay, we've been going at it about an hour. If you need a break, just speak up.
Okay.
We're going to go into gastrointestinal, abdominal type of illnesses. So, let's think about your stereotypical flu, where it's the flu is mostly a respiratory type of illness. It can affect your GI tract with diarrhea and vomiting. The diarrhea and vomiting will eventually lead to what if it's uncontrolled?
Dehydration.
Dehydration, yep. Oftentimes with diarrhea and vomiting, if it goes on long enough, you may experience a little bit of blood in the diarrhea or the vomit. A little bit of blood is not necessarily a medical emergency where you need to call an ambulance and be transported to the hospital. Happens all the time. We get dispatched to the highest level of response, and it's not war story time, but it happened this morning. 42-year-old male was constipated. No longer constipated, now experiencing small amount of blood in his feces. And so we did not run code to the call, even though that's how we were dispatched. And he ended up taking a taxi because he did not need an ambulance. But so dehydration, how are you going to mitigate that dehydration? the short answer is that you aren't going to at the EMT level unless you have some sort of extra training with IV therapy. So your
So that's kind of
paramedic or your advanced EMT can give them fluids and help with that. So something we do run into are GI bleeds, gastrointestinal bleeds. Maybe it's due to an ulcer that's uncontrolled, or they just have some sort of bleeding internally for unknown reasons, bleeding of unknown etiology. So these are going to present in a very smelly bowel movements with coffee ground type of feces in the toilet. There's not much we can do for these guys except good assessment, monitor their vital signs, and transport. Again, these guys are going to have a low blood pressure. They're going to be hypotensive, and they may even want to pass out on you because they're hypotensive. So we typically transport them in a supine position on their back, and we're going to put them in a Trendelenburg position. So they're supine with their legs raised up 6 to 12 inches. Let me get these down. So as far as bleeding control, there's nothing you can do, but they are going to be exhibiting signs of that shock because there is a loss of blood. So they're going to have that be hypotensive and have that high pulse rate. Going to be probably fairly tachycardic. What other GI? So your appendicitis, right lower quadrant pain. As I said earlier, that it's not always, you might have diffuse abdominal pain. I am that guy that had pain for 9 days in my stomach. I just didn't know what it was. I thought it was a bellyache. I thought it was a bug. I finally went to the doctor, and he sent me in for further tests, and I had big plans for the weekend, and he said, "You're going across the street for surgery?" And I said, "I have big plans for the weekend. I can't do that." And he's like, "Your appendix is coming out right now." So where I'm getting at is it could be different types of pain radiating. Some people will describe it as sharp. Some people describe it as dull. Other abdominal injuries are going to be a bowel that they're unable to have bowel movement. You just don't know as an EMT provider. It's usually documented as pain, maybe some rigidity, guarding, and there's not really much you can do to diagnose what's going on. The other thing you're going to have is a AAA. You guys recall what a AAA is?
Abdominal aortic aneurysm.
Yep. Do you recall what the signs and symptoms of that are? So the signs and symptoms are going to be in that abdominal region below the diaphragm, so above the belly button or in that general area. It's going to be a tearing pain. It's going to be a very, very bad, high severity tearing pain. You may or may not feel a palpable pulse. So if somebody's telling you that they have that, you're going to want to lay their hand on the belly exactly where they're describing that pain and see if you can feel that pulse. So that aneurysm doesn't mean that there's hemorrhaging going on in the abdomen. What it means is that there's a layer within that aorta, a vessel that goes out of the heart and pumps blood to the rest of the body. There's 3 layers in there, I believe, and a layer or 2 has separated, and now there's a balloon occurring with that aorta, and it's palpating because there's pulses associated with it. Very large artery. So without rapid transport, immediate treatment, that thing could hemorrhage, and it could bleed out in a very fast fashion. So it's a fairly large vessel that goes down through your body, out of the heart. All right, sepsis. So sepsis is a systemic infection throughout the body after the person has an infection somewhere else. So we see persons with a urinary tract infection that goes untreated. Their body becomes infected, and they have a fever, a general malaise, they're lethargic. They may even be hallucinating, but they are generally very hot and very sick. It could be caused from a knee surgery that has an infection that's untreated. You may not necessarily have, gangrenous and pussy fluids coming out of the knee itself. Maybe it's gone into the bone and the vessels, and it's gone throughout the body. I wish I had a better explanation for you on the physiology behind this, but I know that I know these patients need to go to the hospital right away and get some antibiotics that are much, much higher than they're probably already receiving. So general fever, general lethargia, weakness, difficulty breathing, and they oftentimes will have some sort of previously known surgery or injury or some other nature of illness that could indicate something's going on. All right, seizures. In general, what do people tell me about seizures, guys?
There's so my sister has POTS, so a sign of that is seizure-like symptoms. And
Okay.
when people are generally imagine for seizures, they're basically, flopping on the floor like a fish.
Okay.
But in reality, it could just be like all of a sudden they like tense up and are like, they've got like that 1,000-yard stare going. Like the seizures, it depends on what type of seizure you're seeing. So
Right.
different seizures will have different types of like ways they manifest.
Right. Okay. So you have focal seizures. You have your grand mal seizures, which is the typical tonic-clonic movement. They're unconscious on the ground. Oftentimes is reported as unconscious and not breathing, and then they come out of the seizure. It could be tics, could just be jumping around or maybe moving an arm. Most of the time when we get dispatched to a seizure, most patients know they have a seizure disorder. It's a missed medication. It's an improper dosage of a medication. But we don't often transport seizure patients. If there's a new onset, like, we've gone to a few people that have a seizure for no reason whatsoever, and later to be diagnosed with a brain tumor that they didn't know about. So there are, go ahead.
That's a structural seizure, right? If it's with it like related to a tumor.
I apologize. I don't know.
Okay.
So, the general signs and symptoms are that they're going to be having that tonic-clonic seizure, the ones that are significant, and by the time we get there, they've regained consciousness. They are breathing. They generally have a stare about them. They're in what state? What is that after seizure state called?
Postictal period.
Yep, postictal. So after the seizure, they're going to be postictal, they are, just remember that their brain was starved of all that oxygen. There's all that hyperactivity going on, and they've burned a lot of sugar. So they're just trying to regain consciousness. They're trying to get their brain re-energized. So oftentimes we assess them, we'll take their vital signs, we'll rule out that it's a hypoglycemia emergency. So we'll check their blood sugar, maybe give them a little bit of oxygen, and then wait for them to come out of it. They typically won't initially answer questions appropriately. That's why we give them time. And within 5, 10, 15 minutes, they start understanding what's going on. When we do our assessments, we're checking to see if they're conscious, alert, and oriented. So if we think about that AVPU scale, alert, verbal, painful, or unresponsive. So conscious, alert, are they looking at us? Are they staring at the ground, but they're awake? They're not responding to you. And if they're oriented. So we ask them orientation questions that are appropriate for the person. If they are, 5 years old, don't ask them who the president is. Ask them what their dog's name are, what their favorite candy is, or what their favorite TV show is. You can ask, anybody that's a teenager and older, what day is it? What day of the week? What the date is. But don't ask them what the date is if you don't know what the date is. If you don't know it's the 3rd of August, don't ask them what specific date it is. Keep it broad. What holiday is coming up? Well, it's middle of August. I don't even know what the next holiday is, but if it's getting close to Christmas, maybe it's a couple weeks away, ask them that. Ask them how many quarters are in a dollar. That's kind of a question you got to think about, but it's fairly simple to answer, right? It's 4 quarters in a dollar. So those are orientation questions that we use when we determine whether someone's oriented enough to care for themselves and make their own medical decisions. If they tell me it's 1972 and that they can't wait for it to snow next week and they have no idea where they're at, there's something called implied consent that if someone is unresponsive or unable to answer questions appropriately, under implied consent, we can transport that patient. And the typical person will request that of us if there was something emergency or medical wise going on. So a little sidebar on that. So seizure patients, oftentimes they might bite their tongue. So if they're still in seizure, you can consider suctioning the airway. But oftentimes you just let them have your seizure. You move things away from them. You don't put anything in their mouth, and you transport immediately. If they have a seizure, you get there, and then they re-seize, we just take them. We don't wait for them to come out of it again. There's something underlying going on there. We've been to several calls where maybe the person experienced a head injury from a motor vehicle accident the week before. They had maybe had a little concussion, and now they're having a seizure. Most likely it's related to a traumatic brain injury from that MVC, and there may be a little bleeding going on or something underlying that you don't know. Again, we're talking at a very basic level here. You guys are professionals. You're going to do good assessments. You're not just ambulance drivers like some people want to call you. But you're professionals. You're getting a lot of good education. You're going to be getting a lot of good continuing education. And so make the best decision on what you know. So strokes are fairly significant. We see quite a few of these. What are some signs and symptoms of strokes?
One side is one side of their face is like completely drooped. They're slurring their words. Like a numbness on a side of their body or face.
Okay. Yep. So if we see that droop on one side, what are some other assessment items we can do to determine whether that's throughout the whole body or just in that one area?
Is it that we can ask them to try to smile to see if like I don't remember what the reasoning behind it is, but like they'll be unable to smile if they're having a stroke. Like one side of their face will be unable to smile.
Yep, they've just lost neurological function on one side of their body, so if they smile, they're not going to be able to lift that side of the face. Another assessment tool we'll do is we'll use the Cincinnati Stroke Scale, which is referenced in your book. May ask them to smile, we may ask them to recite a short sentence. Another thing we'll do is an arm drift. We'll have them hold their arms out in front of them, and if one drifts higher than the other, we'll document it as such. Another thing is grip strength. Are they able to equally grip my hands? We'll have them hold my hands and squeeze as hard as you can, and if they're unable to, we will document the weakness on whichever side. Most likely it's going to be the affected side where you see that droop. So there are different types of strokes. What are those different types? So I'll give you, there's a TIA, which is your trans-ischemic attack, and then there are two others.
Hemorrhagic stroke, which is bleeds related.
Say that again.
Yeah.
Hemorrhagic stroke.
Yeah.
The what?
And so hemorrhagic stroke and ischemic stroke.
Yeah. So there's hemorrhagic stroke and ischemic stroke. So what are the differences? Kevin, I want you to talk about ischemic strokes, and Charles, you're going to talk about the hemorrhagic stroke.
So ischemic strokes are more common, and it's usually from a blood clot forming that and then it breaks off and then it travels to the brain and then it blocks out the artery there.
Yeah, good. Yeah, so in simplest terms, it's a blood clot that has lodged itself in a vessel within the brain, and it has prohibited that oxygenated blood to the rest of the brain. So in turn, you have neurological deficits on whichever side of the body. And, it's much like I said with the myocardial infarction, you have that blood vessel within the heart, clot occurs, and it doesn't allow that oxygenated blood. Your heart says, ow, I need that blood. It lets you know. Same with that ischemic stroke. On the contrary, with the hemorrhagic stroke, there's not a clot. So what is it?
So that type of stroke is usually caused by, it's like a weakened vessel that it's ruptured, it's bleeding into the brain. It's usually caused by like an aneurysm.
Okay. Yep, exactly right. Again, yeah, in the simplest forms, it's a weakness in that vessel. It's flowing into the brain, and again, it's not perfusing the certain part of the brain it used to. So one thing that I've seen with these patients is that they have the worst headache of their life. They're still talking to you, they're still consular oriented, but now they're experiencing this horrible headache, and maybe they might be experiencing some nauseousness or vomiting. They could be slurring their words. They may have a facial droop or a weakness on whichever affected side. But both of these patients need immediate intervention at the appropriate medical facility, depending on where you live and how many hospitals are in the area. Might depend on where you transport to. So as you get into EMS, you're going to learn some of that stuff. I'll tell you that where I live and where we transport our patients to, there's one hospital. It's a trauma center. It's a stroke center. It's like they have a cath lab for cardiac emergencies. But depending on your big cities, you might have a stroke hospital and a cardiac hospital and a trauma hospital. You will learn that as you get into EMS. But most everyone can handle all types of emergencies, but it's some specialized in different things. Strokes, ischemic. So what's a TIA then?
It's kind of usually described as like a mini stroke that's caused by like a serious like clot in the brain.
So it's transient. So it's transient ischemic attack. So it might be so essentially what it is it's a stroke, but it's transient in nature. So there might be a blood clot, and then that blood clot goes away. It might come back immediately, an hour or two later, and it might not come back for another month. My grandmother, before she passed, had several TIAs. She was at an age where she had a DNR. She didn't want to be transported every time she had a TIA because most of the time it's self-resolved, but they're transient in nature. I had a guy, probably 45 years old. His TIA affected his vision and his feeling on one side of his face. So he couldn't see out of his left eye. And then by the time we got there, he was fine. But he's like, this is weird. I don't like it. Something's wrong. Take me to the hospital. So as we were taking him to the hospital, I'm doing my assessment. And then all of a sudden he says, sir, I can't see you. Where are you? And I'm like, oh, I didn't move. I'm right here. What's going on? He's like, I can't see out of my left eye again. And I was just in his left eye's view. And so they come and go. It was really interesting to see that happen right in front of me. And that TIA, again, self-resolved before we got to the hospital. But there are thrombolytics that they can administer if it's within a certain time frame. And it's not up to you to determine that. It's up to you to do a good assessment, transport that patient when those assessments occur or when those emergencies occur. Any questions with anything we've covered so far?
Nothing so far. It's just good to hear it like in person, face to face. Like even if it's through like Zoom, it's good to, because reading it's one thing, but actually discussing it is another.
Yeah, exactly. Everybody, I think the majority of people like to be challenged a little bit on the knowledge and know where their shortfalls are, and so this is great. So our diabetic emergencies. What's Charlie, talk to me about hypoglycemia.
Sure thing.
Hypoglycemia.
You said hyper or hypo?
I want you to talk about hypo.
Okay. Hypoglycemia is when your glucose level is lower than normal. Usually the people with hypoglycemia, they usually because they thought I had hypoglycemia for a while, but basically you're consuming like high sugar foods to treat it, and it manifests itself as symptoms of diabetes, and that's all I got. Sorry.
It's okay. Kevin, do you have anything to add for the hypoglycemic patients?
Well, so usually they're more, their level of conscious is usually lower than hyperglycemia.
Okay. Yep.
So they'll also be like pretty, they'll be like pretty dizzy. Feel like weakness or fainting.
Okay. So What, Kevin, do you recall what the normal blood sugar is for a person?
I think between 80 to 120.
Okay. Charlie, do you agree?
I agree.
Okay. Yeah, it's 80 to 120, 80 to 100, depending on your physician and your textbook, but 80 to 120 is the textbook answer. So on any given day, our normal blood sugars run that. If our pancreas is not excreting the appropriate amount of insulin, what are our blood sugars going to do? So insulin is it's considered a hormone that the pancreas produces that allows that sugar into the cell. So I think about a sugar, and I think about the cell and that cell wall, and that sugar is just going to bounce off of it until it's coated with insulin, and then that cell accepts it, it burns it, it transforms it into energy, and you're able to burn it. Now, without that insulin, that sugar is just going to slowly increase. You jump into hyperglycemia. You go into DKA, which is what? DKA.
DKA is a diabetic ketoacidosis.
Yep. So diabetic ketoacidosis, you're going to experience that patient that just generally doesn't feel good, feel really crummy. They could have that fruity ketone breath. And typically these patients are anywhere in that 200 to 600 range. Now, our current glucose monitors only read up to 600 milligrams per deciliter. And so anything above that, it just reads high. So there's another medical term for the patients that read above that, and it escapes me. But anybody that reads high, they need rapid transport. They need further medical interventions. We do not carry insulin. We do not administer it. It is not within our scope of practice or a paramedic scope of practice. So they need that emergency care at a hospital. So for the hypoglycemic patients, anyone that is below that 80 range is considered hypoglycemic. However, someone that is 72, conscious alert, oriented, talking to me, I'm not going to necessarily shove sugar down their throat to get it in that range I think they need to be in. Some people live with just a little bit lower, and that's okay. And it raises and lowers depending on the food that they eat. So they may be at 72 now, they go have a dinner, and then an hour later, they're at 132. And so we're in a range all the time. The typical hypoglycemic patients that we're dispatched to have an altered level of consciousness. They may be unconscious. They're very diaphoretic. What is diaphoretic or diaphoresis? What does that mean?
Moist, like pale skin.
They are, it's sweating. So not necessarily pale, but they're going to be very sweaty to the point where, if you were to drag them down the hallway, your hands would slip off because they're so sweaty. Their shirts are going to be soaked. And they, oftentimes they will be, they're described as having snoring respirations. They may be drooling. They may be spitting, like their lips out, and they're just kind of bubbling spit out of their lips. It's very interesting when you see it, and it's the type of thing you recognize when you get on scene. So one of the first things you are going to do, if it's within your protocols, is check a blood sugar. You're going to choose a finger. You're going to sterilize it with an alcohol prep. You're going to poke it, obtain that blood on your glucometer stick, and check the blood sugar. So one of the things we can do to help a patient that is hypoglycemic is what?
Give oral glucose.
You can give them oral glucose only if what? What's a contraindication of giving oral glucose? So I'm just curious, what are you guys searching on when you're looking this stuff up? You just doing Google
Oh, just
searches?
my notes from the
My notes,
textbook.
my textbook.
Okay, cool. And I'm all for that. I'm just curious so I can help other students in the future.
Oh, if they can't swallow or they're unconscious.
Exactly. Yes. So you don't want to put anything in someone's mouth that is unconscious. They have a chance of aspirating that liquid. So let's just let's work our way from someone that's having a hypoglycemic emergency and they're talking to you. They may not be making sense, but they can open their mouth, they can talk. How would you give them glucose? What route?
It could be given orally.
Orally, okay. There's something a little bit more specific the textbook talks about of where to place that oral gel.
It's like on a stick and just like put it on their cheek.
Yeah, it's given via mouth and then with the buccal. So inside the cheek on the left, we let that absorb through the vessels within itself. If they swallow it, then they swallow it. It just absorbed at a different rate. Oftentimes, someone that has a lower blood sugar that can drink and eat, we will give them juice. We will give them a peanut butter jelly sandwich, anything to get that sugar up. It's not going to be very fast, but I've made more peanut butter and jelly sandwiches in a stranger's kitchen than I care to even remember. But it's the right thing to do for them. They don't necessarily need transport. They may have forgotten to eat. They may have given themselves more insulin than they should have, and it's chewed up more sugar than they thought. Oftentimes, we go on diabetic patients that have had a recent medication change, and so they're just not sure how to titrate. You know, maybe they're giving themselves 12 units when they should have only given themselves 10. So there are a myriad of reasons, and I'd say we transport maybe 1 out of every 20 diabetic patients. Oftentimes, when they reach that level, they get back up in the 50s and 60s, they know what's going on. Our protocols state that we can't refuse anyone until they're in that 70 to 80 range. But if someone's conscious alert oriented, they adamantly refuse to be transported, then we document as such and we move on. Oftentimes we assure that someone is at the house with them to assure they're going to be able to keep their blood sugar up. And but anyhow, so the next person that is so the diabetic, where they're with a family member, they're sleeping, and the wife woke up and the husband's unconscious, not breathing, but he's diaphoretic, he's snoring respiration, he's blowing bubbles out of his mouth. We check the blood sugar and it's 28. What can we do for these guys at the EMT level?
So they don't have any contraindications for oral glucose.
Well, they're unconscious, so we can't depend on their ability to swallow. We don't want to put anything in somebody's mouth. So I'm not meaning to trip you guys up, but there's really nothing you can do other than transport. So this is another indication of needing a paramedic or some ALS intervention. So, make sure if you're going to that unconscious, you have somebody appropriate en route. But you protect the airway, suction as necessary, and transport them. When it's all said and done, maybe they get to the hospital, get the proper sugar they need, they wake up, and they're fine. But you need to do the right thing for the patient at the time with the tools that you have and the training you have under the protocols that you have. If someone's unconscious and they're, as I described, and you have a paramedic en route, they're most likely going to give them an IV and give them something like B50, dextrose 50, and honestly, it wakes them up super fast. But that sugar is a very simple sugar. They're going to burn through it really fast. They need some carbs in their system, some other more complex sugars. The other thing they can give is glucagon. I don't personally see that given as often, but it's certainly something that can be. I saw an ad on Hulu or something yesterday with a type of glucagon that's given intranasally. So there are different things that different people have. Other diabetics will have sugar pills that they can suck on if they're, they feel themselves getting low and they need that sugar right now. They'll suck on those sugar tablets. And true diabetics will know their range. We had a student come. She mentioned she was diabetic. She shared her story. She hovers in that 40 to 45 range. And most people, when they're that low, are going unconscious and they really feel crappy. She just expressed that to us to basically say, see, I'm normal, but I need something to eat soon or else I'm going to crash fast. So it's very, very interesting. What is the how many grams of sugar in a tube of oral glucose?
You said how many grams of sugar are in a tube of oral glucose?
Yeah.
Okay.
Yep.
The book says that one tube of gel equals 115-gram dose.
You are correct. So 15 grams of sugar in one tube of oral glucose. And there's different packagings. There's some gel, there's some twist top, little squeeze packets, kind of like a ketchup packet, but it's full of sugar in a gel form. We've taken that gel and we've mixed it in with juice to add more sugar to it for the ease of drinking it or eating it. In comparison, a can of Monster has something like 50 to 60 grams of sugar. And so 15 grams really isn't all that much. Oftentimes somebody that's low that is still able to take that oral glucose orally will take 2 or 3 tubes of sugar plus other food to eat and such. It does take time. Everybody metabolizes it a little bit different. All right, let's talk about overdoses. So if somebody overdoses on alcohol, what are the signs and symptoms?
Alcohol poisoning?
Yeah. And before you look it up, just go off what you know. Alcohol. It's one of the most accessible type of things we have. What does somebody that's really drunk look like? The book can't tell you that.
They have like a very, based off personal experience watching other people, they have a very poor sense of coordination and balance.
Good.
They're in an they can be in an they're in an altered mental state. They're very like they like slurring words. They're very like being very impulsive, like how they talk, like they're just like blurting out words or like just saying stuff randomly.
Good.
Have
Exactly.
their that kind of thing, you know.
So it may not always be considered a overdose. It could be considered alcohol poisoning. It could be just considered being super drunk. Those are some of the most simple signs and symptoms of that. So what is a intervention we can do for these guys? We're dispatched to a campground out in the middle of the woods and somebody's super drunk walking around. It may be dispatched as an overdose, but what can we do for these guys?
Just like try to keep their airway clear.
Yes, exactly.
Yeah, because they're probably gonna be vomiting or something like that.
Yeah, we want to protect their airway. If it's a situation where they're unconscious, unresponsive, or semi-conscious, they go unconscious, and we're going to be transporting, you're going to be protecting your airway and maybe laying them on their side so they can vomit. But there is no real other intervention we can do for them other than, treating them as a human and protecting their basic airway and breathing. What is an overdose that we have an intervention for?
Opioid overdose.
Opioid overdose. And what are some things that are considered opioids, or what are opioids?
They're like painkillers.
Right. So painkillers such as oxycodone, fentanyl. People take these recreationally. They recreationally abuse them. And some people take them because they just had knee surgery and they're trying to subdue that pain. There are accidental overdoses and there are purposeful overdoses. What's a street drug out there that is an opiate? Heroin. Yep. So, your heroin could be straight heroin. It could be laced with something. Your marijuana could be laced with something. You just never know. So on those patients that we have that are unconscious, we don't know what's going on with them, their friends aren't telling us what's going on, or they're found on a park bench in the middle of the park, we have to go through certain algorithms and troubleshoot what's going on with this patient. So we might do something simple like check a blood sugar. Okay, it's within normal limits. We're going to check their pupils. We're going to check their blood pressure. We're going to check different things. They may have some medical bracelet on them. But one of the things we're going to look at is a possibility of an overdose. It doesn't mean they did, but we're going to give what medication to counteract the opioids in their system.
Narcan.
Okay. And Kevin, what's another name for Narcan?
Naloxone.
Naloxone. Yep. And Kevin, what is the dose that medication comes in, or we could give?
It is
So close.
0.04.
Close.
0.4.
Help them out.
I'm looking at it right now. You said what the dosage is for Narcan?
Yeah. And again, this is one of those that it's manufacturer specific. I honestly can't tell you what the book says, but it's going to be close to this. Go ahead. What do you got?
0.4 milligrams.
No.
Nope.
So 0.4 is a very low dose of that. Your local law enforcement probably carries Narcan, and more than likely it's going to be in a 4 milligram dose. So they carry 4 milligrams of Narcan. They give 2 milligrams up each nostril, so it's administered intranasally. I know that our paramedics carry 2 milligram vials, and they can give it intranasally, intramuscularly, and intravenously. So oftentimes it's given titrated to the overdose and the signs and symptoms going on. So we may not give that whole 4 milligrams right away. We want somebody to slowly come out of that overdose and counteract that. Narcan works very fast. If we give it too fast, it can induce vomiting. It could inhibit protecting the airway. If you have someone that has chronic back pain and they simply overdosed on an extra pill, then that normal amount that they have within their system, you just removed it and sent them into a very excruciating, painful experience. So you may not necessarily want to do that. Of course, when we respond, we're looking at life over limb. We're doing what we can for the patient. We don't want to hurt them, but we don't want to administer. We want to administer what's needed to counteract that opiate and get them feeling better. So we've gone to the patients in the parking lots that are not breathing. They're given ventilations via BVM. We give that Narcan, they come right out of it, and they go, "What are you guys doing here? Leave me alone." We've intubated patients, and they have pulled their tube out when they come conscious, and they say, "Leave me alone." You've taken away their high that they spent their last $50 on, and they don't want anything to do with you. They don't want to go to the hospital. But that Narcan only lasts so long. Again, depending on the person's metabolism, that Narcan only has a certain half-life. So they might go back, they might revert back into unconsciousness depending on the situation. So we always encourage the person to go to the hospital. And if it's someone we really think should go, we get law enforcement involved. We may consider putting someone in protective custody depending on what's going on. That's another topic. Well, in a nutshell, we have talked about a lot of different medical emergencies and interventions that are associated with those, including dosages, routes, 5 rights, and there are more emergencies that you will come across that you're going to have to know what to do, such as someone having a baby, such as traumatic brain injuries, other disorders that you just don't know about until you run across them. Are there any questions with what we went over today?
I don't have it. I think it was good to talk about and discuss, like, okay, what do you do in this scenario? I think that
yeah. So
it,
I hope this triggers you to go back and research some material. I hope that you go back and review that medical assessment that was done in one of our classes. It's in the online classroom, and to kind of help you understand that chest pain patient a little bit more. I'm not going to tell you what scenario I'm going to give you for the final medical assessment. It's not going to be something to trip you up or to see if I got you. We're going to keep it simple. My overall goal is to train you how to provide a basic assessment to where if we're visiting your city, you're on the ambulance that day, that we can come, do a good assessment, you have a good idea of what's going on, and you're able to treat and transport appropriately.